Hello and welcome. My name is Ken Mykowski. I'm the Vice President of Partnership Development at Surescripts. Thanks for joining this webinar about how to get started with electronic prescribing of controlled substances. As a national health information network, we've spent over a decade working with complex regulatory, legal, and technological requirements for e-prescribing. We have also worked with the DEA and industry experts for the adoption of electronic prescribing of controlled substances. Given the complexity and the misinformation in this area, we understand you might not know how to get started. So what we've done is break things down to the four most important steps practitioners and health systems need to complete. With these steps as your guide, you'll be well on your way to the added convenience, accountability, and security of electronic prescribing of controlled substances. Today's webinar will explain these four steps from the perspective of practitioners who are part of an affiliated with a health system. Our speakers will share tips on how they helped successfully lead the implementation of electronic prescribing of controlled substances at the University of Michigan Health System. To walk us through this process, I'm proud to have with us today Dr. Margaret Punch, Associate Chief Medical Information Officer for Ambulatory Care and Clinical Professor of Obstetrics and Gynecology, and Liz Lind, Senior IT Project Manager from the University of Michigan Health System. After their presentations, we'll take some time to answer your questions. Liz Lind, Dr. Punch, along with my fellow pharmacist Ken Whittemore, Senior VP of Professional and Regulatory Affairs from Surescripts, and myself will answer any questions you may have. At any time during the webcast, you can post questions. Just click on Questions and Answers box at the bottom of the screen and type in your question. We'll try to answer as many as we can during the Q&A session. And if you do need help at any time, simply click on the Help button located at the bottom of the screen. Now, before we get started, we actually have a question for you. So please answer the question that is appearing on your screen right now. Did you know that EPCS will be mandatory in the state of New York? I'll give you a few seconds to answer, and then we'll see how you responded. It looks like about 58% of you did know that EPCS will be mandatory in the state of New York. Those of you who didn't know, the state of New York has passed a bill called ISTOP that will require e-prescribing of all prescriptions, including controlled substances, starting on March 27th of 2015. Well, you're definitely in the right place to get started then, so let's get started. To do that, I'll turn things over to Dr. Punch.
Thanks, Ken. I'm a physician here at the University of Michigan, and I use e-prescribing in my own practice quite regularly and have been very happy with the value that it brings both to me and to my patients. We found that it was very important to have a physician champion involved in the project. I'm an Associate Chief Medical Information Officer and was able to play that role here, but it required a number of physicians involved in the project as well. And I would challenge people who are listening in today to think about how they can play that role at their own organizations. We have found it to be quite successful and very easily adopted. As we get into more of the details, I'd first like to tell you a little bit about who we are and what we do here at the University of Michigan. So here at the University of Michigan Health System, we have over 40 outpatient locations representing as many as 120 clinics, and we have 3 separate hospitals that are all geographically co-located in Ann Arbor. We have both faculty and residents and medical students. We are providing primary care, secondary care, and tertiary care, and our patients primarily come from Southeast Michigan, but we also have patients who come from a broad Midwest region and even from around the country. So we did an EHR upgrade, and when this technology became available, it was recognized by our providers that this would be a significant improvement compared to where we were at. Before our current EHR, we had a system where we had the ability to print prescriptions in the exam room with the patients. And with our EHR implementation, we took that away because of the network printing. So the prescriptions were printing down the hall, around the corner, in an office. It wasn't always intuitive where they were, or you would forget them. And that was a problem for our patients as well as for our providers. So when we realized that EPCS was now an option for us, there was a very high demand for it. Patients also recognized that it was confusing why some prescriptions were printed, some were sent electronically, or if they were calling in on the phone, that many things could be taken care of over the phone, but some things we would tell them they needed to drive in and pick up, and that was very confusing to them. We also recognize that for our patients who are on chronic narcotics, who are on narcotic contracts, that this would give us an added degree of security and control around the care of those patients, and that was very important to us. So putting all those things together, this became a very high priority project for us. So we decided we wanted to do this, but then we knew there were going to be a lot of details involved in actually accomplishing it. And so we brought together people from the technical side, from the operations side, and really started to build our project team and expand the stakeholders that we had involved. And that included technical folks. It included our compliance office, our legal office, who helped us interpret the regulations, reread, ask questions of the DEA, get it all sorted out in a way that we could move forward with it, as well as our operations folks, because we knew that we needed to issue the 2-factor authentication devices and do all those pieces of the work as well. So it really was bringing together all those people to accomplish this high priority project. We wanted it done right away, but we knew it was going to take some time. Ultimately, it took us about 8 months from when we started to when we achieved implementation. We've been live now for over a year. We have 1,400 practitioners enrolled in the e-prescribing of controlled substances. That includes faculty, residents, as well as mid-level providers. And we are seeing prescriptions being sent to over 750 pharmacies, and that is representing now about 64% of all the controlled substance prescriptions that we're writing here at the University of Michigan.
Thanks, Dr. Punch, for sharing your experience. Now, at this time, many of you may be wondering if your EHR application is even certified for EPCS. We're glad you're thinking about that. Actually, that might be interesting for all of us to know as well, so please answer the question that is on your screen right now. All right, about 56% of you do know that your EHR application is certified for EPCS. 26% of you know that your EHR is not certified for EPCS, but about 18% of you don't know, and you need to find out. To help clarify this and know the steps necessary to get up and running with electronic prescribing of controlled substances, let's hear from Liz Lind, Senior IT Project Manager at the University of Michigan Health Systems. Liz?
Thanks, Ken. We're happy to be here to organize this educational session with Surescripts. We at the University of Michigan Health Systems were one of the first organizations to widely adopt electronic prescribing of controlled substances. We learned a lot about electronic prescribing of controlled substances in our project, and we are very happy to share this with other organizations because we know how valuable it would have been if someone could have shared the same information with us. So this diagram represents our big picture overview of DEA compliance for the electronic prescribing of controlled substance process. We use this with our management in order to explain to them that there was more than just software certification involved. And so if you look at the colors on the diagram, the yellow colors indicate where we, the University of Michigan Health System, had responsibilities to demonstrate the DEA compliance. The blue colors were where our vendor had responsibility to be certified for DEA compliance. There's also a green block, which shows the Surescripts process, and a red block, which shows the pharmacy process, because the pharmacies themselves also have to be certified to receive EPCS. You can click on the green resources button at the bottom of your console to download this diagram. As you can see from our big picture diagram of EPCS at the University of Michigan, it is a complex process. And it may be confusing as to where to begin. So what we're going to do today is we're going to break this down into 4 steps that are unique to EPCS projects. Before you begin your EPCS implementation, it's very important to define whether you're going to follow the individual practitioner or institutional practitioner guidelines. When you read the DEA regulation, the intent of the regulation appears to be to set the bar a little bit higher for the individual practitioner, which makes sense when you consider that an institutional practitioner would have inherent oversight of EPCS processes with things like a compliance office, a credentialing office, and EPCS policies. So when we, the University of Michigan, looked at this, we determined that our individual providers were, in fact, individual practitioners. But because we, UMHS, is an institutional practitioner, and our individual practitioners are using our system, we're following the institutional practitioner guidelines. The DEA language is not real clear in this area, and it took us at the University of Michigan several weeks of discussion to come to agreement on this definition. Let's start with the 4 steps. Step 1, you need to ensure that your software has been certified for EPCS. You can do this 2 ways. You can either contact your software vendor, or you can look on the Surescripts site to see the software applications that have been certified. At the University of Michigan, we did need to upgrade to a more current version of our software, upgrade our interface, and install a digital signature server. We had planned to do the upgrade anyway, so really the only additional work for us was the installation of a digital signature server. Step 2, identity proofing. Identity proofing is essentially proving that you are who you say you are. At the University of Michigan, because we follow the institutional practitioner guidelines, we had the option to do this internally. So we met with our legal, compliance, and credentialing offices, and we determined by reading every step of the DEA regulation that our existing credentialing processes meet the DEA's requirement for identity proofing. So for the University of Michigan, that meant that we had no additional work for EPCS identity proofing. As an institutional practitioner, you have the option to do this internally, like we did at the University of Michigan, or you can go to one of the certified third parties for identity proofing services. Step 3, 2-factor authentication and issuing authentication credential. 2-factor authentication is 2 of the following 3 things. 1, something that you are, such as a fingerprint. 2, something you know, such as a password. Or 3, something you have, such as a token. At the University of Michigan, we first looked at 2-factor authentication solutions that we had already deployed. The first one we looked at was a tap-and-go type solution. The hardware, unfortunately, the card and the card reader, did not meet the DEA EPCS requirements. The second solution we looked at was a soft token. The soft token in this case was a phone application. The concern we had about this was that the DEA regulation states that the provider must not conduct EPCS on the same computer that they generate the token code. So we ended up going with our third option, which was a hard token. The hard token is compliant with the DEA regulations. It removes the option of creating a token code and doing EPCS on the same device, and it will always be a good secondary solution for us. So if in the future we do go to a more user-friendly type solution, such as a fingerprint reader or a tap-and-go type reader, the provider can always use the hard token at any location such as their home. Once you select your two-factor authentication solution, you need to figure out how you will issue the authentication credential. At first, we thought issuing the authentication credential meant who would hand the token to the provider. What it really means is this is uniquely binding the provider to the token solution. You will need to work with your identity management office in figuring out how to do this. Now, at the University of Michigan, we do use our token for multiple purposes, so this was probably harder for us than many other people. What we had to do was we built a web application, and we trained people in our department so that they could sit down with the provider for a quick 5-minute process where they did an EPCS token registration, in addition to the normal campus token registration. And finally, step 4, setting the software security access. The DEA refers to this as logical access control. The DEA requirement is that 2 different people must perform 2 steps in the system. Now, these 2 people can be on the same team. The way our software vendor implemented this, the first step is the provider's record is updated. The EPCS status is set to pending. This generates an in-basket message which goes to a second party. The second party reviews the message and either approves or denies the provider's request for EPCS status. Once it is approved, the provider then receives a message letting them know that they can now perform EPCS in the system. The final point I want to make here is around separation of duties, because we spent quite a bit of time trying to decide who should perform these 2 steps. The DEA states that whoever does the identity proofing needs to be different than whoever issues the two-factor authentication credential, needs to be different than who does the logical access control. So for us, the identity proofing is done by our credentialing office. Issuing the authentication credential is done by our departments and programs. And finally, it is our EHR security team that performs the logical access control. We hope that the example we have provided you today, as well as breaking this down into 4 steps, has helped demystify the process of implementing electronic prescribing of controlled substances. Additionally, we have a diagram available of our provider onboarding processes at the green button on your console. Thank you.
Thanks, Liz. That was helpful. Now that we are clear on the necessary steps practitioners must have completed for EPCS, many of you may already have a sense of your timeline for implementation. So if you would please tell us on this next polling question, when do you expect to get EPCS? Perhaps you already have it. You might be getting it soon. And of course, we realize that many of you don't know. Go ahead and answer if you have not done so yet. Okay, the majority of you are not sure. About 30% of you will be getting it in 6 months. 14% in the next month, and about 10% of you have EPCS already. Thank you very much. Whenever you are going to be getting EPCS, I'm sure you'll appreciate these additional valuable insights that Dr. Punch is about to share on the impact that electronic prescribing of controlled substances has had on her, other prescribers, and their patients. And don't forget, our Q&A session is coming up shortly, so submit your questions at any time in the box on your screen. Dr. Punch?
Thanks, Ken, and thanks to Liz for that great explanation. There is a lot of pieces to that that your technical teams need to accomplish and that everybody gets through it together. But once you get it done, the provider onboarding is really pretty straightforward. So your providers can do a little bit of e-learning and then sit down with whoever's going to be doing their identity proofing and binding them to their tokens. It's really, for us, it didn't take very long, and it was very readily accepted by our providers to sit down for a few minutes with somebody they know and achieve that, and then they were good to go. All right, so e-prescribing of controlled substances really is just a natural extension of your normal e-prescribing workflow. You get an extra pop-up screen, which is just the validation screen for that prescription. Double check your numbers. double check your pharmacy, check the box, move on to the two-factor authentication, just add that second little password or whatever you're doing in there, and off the prescriptions go. So it's really pretty straightforward, not intrusive into what you're doing. The monthly reports are required by the DEA, and we haven't really found those to be intrusive either. It's helpful to just see what you did last month and remind yourself who those patients were and make sure there isn't anything you didn't expect there, but so far we haven't had any concerns with that at all. So we made it a voluntary enrollment process for providers. We didn't force anybody into this. We did find that providers were very willing to get onboarded. It was their priority that drove us getting to e-prescribe controlled substances in the first place, so they were ready for it. There were a few clinics where it was confusing because some providers were EPCS prescribers and some were not, and patients were figuring that out, and they wanted things sent electronically from all the providers, so we did have a few clinics that essentially mandated that all providers get on board with EPCS, and that's been successful for us. We feel that we're seeing higher and higher percentages of these prescriptions being sent electronically as a reflection of the satisfaction with it overall. So that's been a very positive experience for us. I will just tell you one story from my own practice as an obstetrician. I had a patient recently who'd had a C-section, and she reached out to us because she was running out of pain medication. And over the phone, we were able to assess that she didn't have any concerns for infection or other complications. We were able to talk about how she was taking the medication and when she was taking the medication, and realized that we probably just hadn't quite given her enough when she was in the hospital and going home. And it was really nice to be able to just send a prescription off to her local pharmacy and know that while she's managing an incision and a newborn baby, all she had to do was make a stop at her local pharmacy. In the past, it might have been sending something by mail, sending something otherwise, or having somebody drive into the hospital to pick something up for her. And so the e-prescribing of the narcotics was really just the right solution for her and for her family. So it's really nice to be able to provide that to our patients and know that we're providing great care and that's part of our package, that we can help her get what she needs when she needs it. So overall, I would say don't be daunted by the fine details of the DEA requirements and regulations. Be a champion and know that this is something that can make life easier for you and better for your patients, and get there, because you can do it. We did.
Thanks again, Dr. Punch. All right, now that you understand the 4 key action steps for getting going with electronic prescribing of controlled substances, you may have specific questions. To participate in our question and answer session, just enter your question into the appropriate field in your computer screen. On hand to answer your questions, we have Dr. Punch and Liz Lind, as well as our veteran pharmacist, Ken Whittemore from Surescripts. Okay, our first question. This is for Ken Whittemore. Do the 4 EPCS implementation steps outlined for physicians apply universally, or are there other steps that some physicians may need to take place?
Thank you, Ken. Actually, for most of the country, those 4 steps are what applies. There is an additional step that folks in New York need to keep in mind, and that is that the Bureau of Narcotic Enforcement requires that both practitioners and pharmacies register their EPCS-approved software with the Bureau of Narcotic Enforcement before either sending or receiving EPCSs. So that, if you were in the state of New York, is probably what we would consider the 5th step.
Thank you. I have a question for Liz. Liz, what was the biggest barrier to get going with EPCS implementation process? And then looking back, what ended up being the biggest challenge to complete?
I would say the biggest barrier in getting started was educating our own management about the fact that we had to do an EPCS onboarding process. Initially, everybody thought, well, the software has been certified. Let's get a two-factor authentication solution and start doing EPCS. So we had to educate them about the identity proofing, issuing the authentication credential, and the logical access control. And additionally, we had to educate them to the fact that we had to do these tasks in accordance with the DEA regulation. And what ended up being the biggest challenge, looking back, was in fact those onboarding processes. So it was putting the whole process together from end to end, all the discussions on making sure that we had a complete process that met the intent of the regulation. And then specifically for us, it was issuing the authentication credential. We had to do some additional build. We created a web application, and we created an additional functional duty where we had people do our token registrations. So that was the most additional work.
Thank you, Liz. Dr. Punch, I have a question for you. Now that you've experienced using EPCS, where do you see the most benefit accruing? Is it for you, the prescriber, your office staff, or your patients?
Well, I would say it's probably really a shared benefit. For patients, there's definitely an added convenience to it. And for the physicians, I think the ease of it and the security of it has been very satisfying. And of course, nurses who used to be the ones and office staff chasing around the pieces of paper love it as well.
Thank you. Thank you. Ken Whittemore, we have another question on EPCS as far as it being mandatory in New York. Are there other states where EPCS will be mandatory?
Not as of this point in time. There have been a couple of other states who have considered it. For example, there was a bill in the California legislature this year that was discussed that, had it passed, it would have made EPCS mandatory, but that bill did not succeed. So currently there are no other states that have officially adopted the same mandate as has New York, but I think it's safe to say that there are quite a few other states that are watching what's happening in New York, and if that goes well, they will probably follow down the same path.
Thank you. Liz, a question for you. You answered one of the question is, what are some of the initial challenges at Go Live, and then how does the soft token work exactly? Could you get in a little more detail on the use of the soft token?
Sure, I'm happy to talk about the soft token. Now, one thing I would also say, though, when you read the DEA regulation, they only use the term hard token, but if you look at how they define hard token, it would encompass what I'm about to define as a soft token. So a soft token typically means it is a password code that is generated on a device. So, for example, it might be an app that you download to your phone that then generates a 6 or 8 digit code that would be your code that you would use for EPCS. So that's what we mean by soft token. And so why we avoided the use of the soft token is the DEA regulation states that you have to have a hard token that meets the standards of the FIPS 140-2 Level 1 and is on a device independent of the computer that you are going to perform EPCS with. So just to avoid any chance that somebody would generate a token code on the same device that they're performing EPCS, we went with a hard token.
Okay, thank you. Here's a question I'll handle. Do you find that pharmacies are not yet compliant, so there are limited locations that can accept PCS? How are we handling this? Today, about 70% of the pharmacies in the United States, about 46,000, are currently on our directory for EPCS. A good many of those that are not yet on our directory have certified software and just need to go through the process of implementing that software and then placing themselves on the directory. So we have very, very good participation in the retail pharmacy world, both the retail chain stores as well as the independent pharmacies. you can always go to our website, and I'll talk about that again later, and we have functionality where you can put in your zip code and specifically ask for which pharmacies are accepting EPCS prescriptions, and do that by mile radius, and it can tell you exactly what stores in your area are available to take EPCS. Dr. Punch, another question for you. Are you using EPCS for discharge prescriptions from your inpatient hospital as well as in the ambulatory sites?
We are. We went live with our inpatient EHR just this summer, and we did implement e-prescribing at discharge at that time. We have had an issue with one of the pharmacies that is one of the local chains not accepting the residents' institutional DEA numbers. I know there was also a question about that, and it's because of an intermediary that they were using with the way things were processed. And so we are working with that chain to resolve that, because it wasn't getting caught as something that wouldn't e-prescribe, but then they were not accepting them. So we have had one problem with one grocery store pharmacy chain, but otherwise it's working quite well.
Thank you. Thank you. Liz, a question for you again. Do you have any physicians coming into your system that have their own tokens? And if so, did you allow them to use them?
That's an interesting question. So we actually did have physicians who already had tokens in their possession that they are able to use for EPCS. Now, it's the exact same token and exact same token system that we all use. And part of why we selected this token was because it had already been deployed at the University of Michigan. Our system is right now integrated to only work with one token. We perhaps in the future may integrate our system to work with two different tokens, the one being a more user-friendly, say, fingerprint device type system. But even for those providers who already had a physical token, they had to go through a second registration. And that was the issuing the authentication credential step that ended up being significant work for my project team, because we didn't want just because someone had a token that they could use that token for EPCS. They had to go through one additional step to register the token specifically for EPCS.
Thank you. Thank you. I have another question about pharmacies. Have we had many issues with pharmacies denying or refusing Schedule II prescriptions? And the answer to that is yes. We have had reports where pharmacies who are on our directory as having gone through their audit and been certified for EPCS, having pharmacists inform doctors that they would not take or would refuse prescriptions. This is one of the barriers that we've noticed, not only for this process, but this reminds us of the early e-prescribing days of 10 and 12 years ago, when e-prescribing was just starting to come around, and pharmacists did not know they can accept electronic prescriptions. So there are knowledge gaps, and there is some misinformation out there, and we have been working with the pharmacy management system companies as well as our retail pharmacy chain stakeholders to remind them to make sure that their pharmacies and pharmacists understood that e-prescribing is in fact legal in their state, and they do have compliance software in order to accept that. We know that this is probably going to continue to happen, especially on a weekend evening with a relief pharmacist who may not be as well aware of the law as to whether or not they can take a controlled substance prescription or not. So we're asking for patience there, and if this happens, please let us know, and we'll get to pharmacy and pharmacy systems to help them inform their pharmacists as well.
And I would just add to that we did some proactive communication with our top prescribing pharmacies before we went live. So we reached out to them to let them know we were going to start doing this before we started, and I think that helped us some, but we did have all those same experiences.
I think that's a great idea. We've been telling our EHR stakeholders that as they're going live in an area, let us know, and we'll reach out to our pharmacy stakeholders to let them know that things are happening. With the mandate in New York, we've told people, let us know when you're going to have clinics going live, and we'll reach out to our top pharmacies to make sure that they know that that's happening. Dr. Punch, there's a question here that says you said you had 1,400 providers currently using EPCS. How many were you expecting originally when you did your planning, and what method did you use to assess the level of participation?
Well, I think we bought 3,000 tokens, just in wild hopes that we would have 100% enrollment, recognizing that our colleagues in pathology and radiology and some of the other departments had absolutely no need for this at all. And we, I would say, have generally been very happy with the uptake. We, as I said, didn't insist on it. There are many faculty who are not the active prescribers in their practices. They have mid-level providers or residents who do that for them, and so I would say we're satisfied with where things are at, but we're also making sure as we bring in new faculty and new residents every year and new mid-level providers on an ongoing basis that it's offered and encouraged.
Thank you. Liz, another question for you. How much involvement from the DEA did you require? Is there something necessary to register your technical staff and who you are authenticating users for EPCS?
Well, technically, you do not require the DEA to be involved in you putting all of your processes together and implementing EPCS at all. Now, if you happen to be lucky enough to be able to get some feedback from them, that would be great. One of our big challenges in putting together what we loosely call the onboarding processes, where we had to read the DEA regulation ourselves and interpret it and determine that our processes met that or not. We did receive some informal feedback from the DEA when they looked at our processes that they looked fine, and they did have a few suggestions. Let's see this. So the second part, is there something necessary to register your technical staff who are authenticating users for EPCS? So I believe what we're referring to is when you are going through the logical access control, it is a two-step process. And the DEA requires, if you are following the individual practitioner rules, that the person who authenticates the user for EPCS be a DEA registrant. Now, as I mentioned, we follow the institutional practitioner guidelines, and the institutional practitioner guidelines do not require a DEA registrant to give that final approval and the logical access control for EPCS.
And that's really one of the key things that are different from an institutional situation versus large independent or even small practices. They're going to have two people do that local access control, and one of them is going to have to be a DEA registrant who's gone through ID proofing, who has a token, and that needs to be one of the people. That's one of the major differences, isn't it, Liz?
Yes, the other major difference is that with the identity proofing, you have to go to a third party as well.
Yes. Ken Whittemore, what occurs if the receiving pharmacy is not certified to accept EPCS?
Well, in actuality, it won't be possible to send an EPCS to a pharmacy that's not certified. This is something that we on our network take into consideration with our pharmacy directories. So when a prescriber wanted to send a prescription to a specific pharmacy, they would look into their application, and from the display in their application, they would be able to tell whether that pharmacy would be able to receive an all-electronic controlled substance prescription or not.
So
and Ken, I'm going to go ahead.
I was just going to say, if we try to prescribe to a non-EPCS pharmacy, it automatically prints it.
And that's functionality you have within your EMR?
Yes.
Yes.
Because it knows from the pharmacy, sorry.
Yeah, yes. Ken, I'm going to stay with you. There's a question that says, do you anticipate that New York State will consider delaying the implementation of EPCS, considering that there are only 30 to 40% of the pharmacies that are ready to accept an EPCS prescription?
Well, there are a couple of things there. First off, in the dialogues that we've had with the Bureau of Narcotic Enforcement, the Board of Pharmacy, and other state agencies in New York, all indications at this point is that a delay in that mandatory adoption date is not likely. It's in statute. It's something that would have to be addressed by the legislature. And again, the folks that we've talked to up there are just not giving us any indication that at this point will be a probability. They plan to enforce the regulation when it does take effect. So that's I guess there's always a possibility that something might happen in the legislature at the very last minute, but I don't think anybody would be well advised to count on that.
And not only that, what we know is that there are about 60% of the pharmacies in the state of New York that are qualified for accepting EPCS. And we are working with both the State Board of Pharmacy as well as the New York Pharmacists Association to make sure that the word is getting out that they need to be up and ready by the March 27th date.
That's right.
I have a question that I'll take, and Ken, you might want to add in as well. I understand there's also a component that has to be completed by the pharmacy to be certified to accept EPCS. Can you expound on this? Pharmacy management systems need to go through a 1311 audit initially and every 2 years, similar to what the EHR software has to go through as well. But once they go through this audit, individual pharmacies don't need to do anything, except again in the state of New York, where pharmacies need to register with the Bureau of Narcotic Enforcement. So there is that extra step for pharmacies in the state of New York, and the software does have to be audited by an outside 1311 auditor. Ken, do you have any other thing you want to add to that?
No, I think you covered it pretty well, Ken.
Okay. Liz, a question for you. What is your process for lost tokens?
Well, our process for lost tokens is driven by the DE regulation, because the DE regulation very clearly states the provider has a responsibility to report a lost token within 1 business day. So really one of our first goals there was to ensure that we communicated this to providers so they were aware of this fact. If they do not report their lost token within 1 business day, they can be held liable for any prescriptions written using that token. Now the process itself is, I mentioned we have that special EPCS token registration, that additional registration for our hard tokens. The provider can contact either our service desk or can contact their liaison, the person who initially registered them, and they can immediately revoke privileges to that token. So once they turn that token off, the token no longer works in the system.
Okay. Liz, I'm going to stay with you, and can you explain in more detail what the identity proofing process entails?
Right. So I can't really go through step by step what's in the regulation itself, but I can tell you what we did to ensure the identity proofing works for us. So I basically had a big meeting where I brought our credentialing office, our legal office, our compliance office, my own project team, several other people we needed to have in this discussion, and we read through every single requirement in the DEA regulation for identity proofing, and we mapped it to our existing credentialing process. So I guess just a couple of the highlights. You need to show a picture government ID. This needs to be done face-to-face. You know, those would be the only highlights I would cover. But the key is sitting down with the key players in your organization and stepping through the DEA regulation just to ensure that you comply with every single step.
For doctors who are not in institutional practices and are either going to be either go through in-person ID proofing or remote ID proofing via the internet, for example, they're most likely going to, again, as Liz stated, need to have a government-issued picture ID. like a driver's license or a passport. They're probably going to need to have a copy of their medical license as well as their DEA license, and may need other proofs of residence like a bank statement and or a utility bill. Those who are going to be doing remote ID proofing will probably go through either Experian or Equifax questions where you will be asked questions that only you will know the answers to. Similar to what you would do as if you were going to be asking for a credit report. So there is a little bit of a difference as to what physicians need to do in the institutional versus the non-institutional setting. Ken Whittemore, does a prescriber have to do two-factor authentication for each prescription, or can a set of prescriptions be created and then authenticated in a batch by a prescription?
They can actually sign EPCSs in a batch at the same time, so they can create 2 or 3 or 4 prescriptions and get them prepared, and then they indicate which of those are to be signed, and then they go through the two-factor authentication signing process, and they all of them would get signed at the same time by one application of the two-factor authentication.
And can they do this for multiple patients, or is this just for a single patient?
No, that would have to be, no, you can sign multiple prescriptions for the same patient at one time in a batch, but you cannot sign, you have to use the two-factor authentication individually for each patient, if you will.
Okay. Dr. Punch, a question for you. Some physicians have expressed concern that EPCS will be disruptive to clinical workflow. Has two-factor authentication been successfully integrated into your clinical workflow from your point of view?
Yes, it has, because it was more disruptive if you were prescribing both controlled and non-controlled substances to have the non-controlled substances go electronically and have the controlled substances print. So to have everything that you're prescribing at once be handled in the same way is a big improvement over the previous workflow where some things printed and some things went electronically. And it also gives you the flexibility to do, telephone work and non-visit related work from an office or from home or from any location that you have your EHR.
Thank you. Thank you. There's a question here that says, can you explain the certification process for an EMR vendor? An EMR vendor, again, is going to need to upgrade their software that complies with the DEA IFR. They're going to need to then have a audit by an outside third-party auditing firm that can do a 1311 audit. This is an extensive audit, and it makes sure that the EMR software is compliant with the DEA rules. EMRs are also going to have to go through a Surescripts certification. This is a relatively lightweight certification, I think somewhere between 7 and 10 test cases versus the 1311 audit, which in times there are over 100 test cases, in order for you to be certified to transact on the Surescripts network. So those are the basic certification processes that an EMR is going to have to go through. Liz, I have a question for you. Have you evaluated your provider's response on the usability of two-factor authentication? What kind of reaction are you getting to this process from your providers?
Well, as I mentioned in the selection process, the hard token was not the first choice. The providers would prefer something less intrusive, something where they didn't have to carry anything additional or type in additional digits. So, obviously something like a fingerprint reader would be more preferred. But quite honestly, providers have been so happy to have this additional functionality that we have received almost no negative feedback about the fact that they do need a token and they do need to type in the digits. Dr. Punch, would you like to add anything?
I would just say just the flexibility that if I just have that little token with me, I can do it anywhere, as opposed to needing a machine that had a fingerprint reader or a tap-and-go device or something else. I think the one option that providers would like to consider now that most folks seem to have a cell phone in their pocket would be a cell phone option, but we have not necessarily encouraged providers to carry cell phones with them when they're doing clinical care. and they all it's just personal devices rather than devices that the practice has supplied. So that would be the one I think that I've heard an itch for, but otherwise they are just very happy to be able to do it. And the token is small enough that it's on a keychain or on your ID badge or something that's usually convenient.
Here's a question I think I can help for. It says EPCS requires a system audit every 2 years. Who will be doing this for the University of Michigan systems? I think I want to clarify that the every 2-year 1311 audit is something that the EHR is going to have to go through. So in the case of the University of Michigan, it would really be EPIC that would be needing to go through a 1311 re-audit every 2 years, and then making sure that the University of Michigan had a copy of that certificate. So it's not the individual institution that's going to need to go through a 1311 audit. It's going to be the EHR software itself. There's a question here, and I don't know if you can answer this, but what determines whether or not you're an institutional practice?
That is a tough question, and we spent a lot of time here debating if we were going to follow the institutional practitioner guidelines or the individual practitioner guidelines. The only advice I can really give you is you need to work with your legal and compliance office, and you need to look these definitions up in the DEA regulations. As I said, we view the University of Michigan Health System as an institutional practitioner. And when you read the regulation, a lot of places, the way they phrase this is they say, if you have individual practitioners using an institutional practitioner system, and then they basically state the institutional practitioner guidelines. So again, my advice is you are going to have to work with your own legal and compliance office to come to agreement on those definitions.
Thank you. Here's an interesting question that we've had before. Following the guidance for individual practitioners, how does the first registrant in the practice get approved? So if you have an individual practitioner using an EMR or point-of-care system, they need to work with their EMR in order to go through the ID proofing, get their credentials so that they can get their two-factor authentication token. Once they get those things, now they have to do the two-person role access authentication. And it may be that in an individual practice that will be your office manager, and it doesn't, the law doesn't indicate that that person has to be an employee. But the second person, since they need to be a DEA registrant who's gone through this process, may be that individual practitioner themselves. So yeah, it's kind of like, can an individual practitioner actually do their own role access authentication? And there really isn't any other way around it but then using the practitioner themselves as well as some other individual, probably an office manager. Ken W., do you have anything there that you want to add?
No, I think you summed it up pretty nicely.
Okay. Here's a question for you then, Ken. Can you send 3 prescriptions for a med with different start dates for a patient so you don't have to remember to order it each month?
Yes, you can. That is allowed by the DEA's EPCS regulation. It's something that obviously the EHR would have to build into the system. I think all of them are doing that. And then at the pharmacy system, the pharmacy would have to have a method of flagging when those prescriptions that have a do not fill before date become eligible to be filled. But yes, it is possible to send those in compliance with the DEA's rule.
Thank you. Ken, I'm going to stay with you. Do pharmacies in Pennsylvania need to register their software with the DEA?
Well, actually, and I'm not going to restrict this answer to Pennsylvania. This is a misconception that I think a lot of pharmacists have, that their software needs to be registered with the DEA. And actually, there are no software applications either on the EHR side or the pharmacy side that are registered directly with the DEA. The DEA has outlined various requirements that have to be met and identified a number of different types of entities that are available to do the Part 1311 audits that you mentioned earlier. And it is those entities that do the audits, and once the audits are complete, they give a certification to the EHR or the pharmacy system vendor indicating that they have passed the audit. And if a pharmacy is interested in making sure that their application vendor has gone through this process, it is their right under the DEA's rule to request a copy of the Part 1311 audit report, and the vendor must supply that to them. So again, that's a way that the pharmacist and prescribers can also know with certainty that their applications have gone through the process.
Thank you. This is a question for either Liz or Dr. Punch. What group or department owns the daily incident report, and do you run this report on weekends as well?
I'll go ahead and take that one. So we ended up having that report go to our clinical security team. And again, this in part has to do with the way that our vendor implemented the report. The report is very technical in nature. It has actual server addresses in there and a lot of information that you really need technical people to take a look at to even make heads or tails of what's going on. So we ended up giving that to our security team.
Okay.
Oh, I'm sorry. The other part was, do we? Yeah, we do run it every single day of the week.
Okay. Thank you. I have another question about the certification process. What's the difference between a certified vendor and audited vendor? You need to go through a 1311 audit by an 1311 outside auditor. The certification process with Surescripts needs to take place in addition, and frankly, we suggest doing it at the same time or as you're getting started. So it is a two-step process. There is a outside audit as well as a Surescripts certification process. I have an interesting question. Many child psychiatrists are in solo practice with no office manager. Who can serve for as a second person for the role access authentication process? And again, I would suggest that in that practice that you work with your EMR. Your EMR may have someone who can help you and act as that second person. As I said, it does not need to be an employee of the physician group, but someone who will attest that that doctor has gone through ID proofing and has received their token and is who they say they are. So your EMR may be able to help you by providing that second person. We're going to take another question or two as we're getting near the end of the hour. Dr. Punch, were there many challenges or any challenges with getting residents on e-prescribing for controlled substances?
Well, getting them to the token, to the binding process for the token was a challenge just because they are always on the run and on the go. So actually finding them 5 minutes to sit down with the person to do that was a little bit of a challenge. And then, as I said, one of the pharmacies were struggling with their institutional DEA numbers. But otherwise, it's not really been too challenging.
Okay. Thank you very much. All right. Our time is just about up. Thanks to all of you for your questions and for joining us today. We hope hearing real-world experiences and seeing things broken down into 4 simple steps gives you the clarity and confidence needed to get started with electronic prescribing of controlled substances for your practice. In a few days, you will be receiving an email with an archive of this webinar that we encourage you to share with your colleagues, along with any other tips you may have learned today. As a reminder, you can find the EPCS project overview for DEA compliance, as well as the PowerPoint slides from this webinar by clicking on the resource button found at the bottom of your viewing console. If you'd like additional help getting started, please visit www.surescripts.com/EPCS. Contact your EHR vendor or your IT department and download the webinar slides and resources. On behalf of Dr. Punch and Liz Lind, Ken Whittemore, and myself, we appreciate you spending some time with us to share best practices for the adoption of electronic prescribing of controlled substances.